Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 461 of our pharmacotherapy series, which majors in pediatric malignancies. The next case reads, NTB is a 12-year-old boy with T-cell acute lymphoblastic leukemia. Initially he responded to therapy and achieved a complete remission. However, about 17 months after his initial diagnosis, NTB undergoes a routine lumbar puncture as part of his planned maintenance therapy. Analysis of the CSF indicates the presence of numerous lymphoblasts. A CBC reveals the following: a hematocrit of 29.5%. A platelet count of 120,000 cells per microliter. WBC of 5,300 cells per microliter, with 45% lymphocytes, 50% neutrophils, and 5% bands. A bone marrow biopsy confirms relapsed acute lymphoblastic leukemia with 53% lymphoblasts. So my questions to you read: what are NTB's chances of achieving a second remission and long-term survival? Are there specific features about NTB's relapse which confer a worse prognosis? NTB is asymptomatic at the time of relapse, as are most patients experiencing a relapse of acute lymphocytic leukemia. Most of these patients are diagnosed by routine CBCs or lumbar punctures. Although acute lymphocytic leukemia patients typically have excellent responses to treatment after relapse, 20% to 25% of patients will relapse again, and most will not be long-time survivors. Routine bone marrow biopsies may identify bone marrow relapses before they become evident on a CBC, but it has not been demonstrated that earlier identification of bone marrow relapse by morphologic criteria impacts long-term survival. At least 80% of relapsed acute lymphocytic leukemia patients will achieve a second remission with salvage chemotherapy. Unfortunately, bone marrow relapse in childhood acute lymphocytic leukemia is associated with poor long-term survival, and most patients will not be cured of their disease. Rates of 5-year disease-free survival vary from 6% to 60% for patients with bone marrow relapse and are dependent on multiple variables. NTB's situation has several features which confer a worse prognosis on relapse, including male sex, both marrow and CNS relapse, T-cell disease, and relapse less than 18 months from initial diagnosis. My next question to you reads: which treatments could be used in an attempt to attain a complete remission and improve NTB's chances of long-term survival? Agents used in salvage regimens are similar to those used in high-risk acute lymphocytic leukemia regimens. In general, treatment usually consists of an intensive 4-agent induction regimen of vincristine, prednisone, daunorubicin, and asparaginase. This is accompanied by radiation therapy to sites of local relapse, e.g., testis, CNS, and intrathecal chemotherapy. After this regimen has been completed, the patient may continue with courses of intensification therapy, continuation therapy, and intrathecal therapy. Relapsed regimens will include more intensive chemotherapy, including high-dose methotrexate and high-dose cytarabine, abbreviated as HIDUC, as well as etoposide and cyclophosphamide. High-dose methotrexate has excellent penetration into the central nervous system and can be used to treat and prevent CNS leukemia relapses. High-dose cytarabine, that is, 3 grams per meter squared every 12 hours for 4 doses, in conjunction with standard dose asparaginase, may be used to induce a remission in patients who fail re-induction therapy. This approach has been successful in approximately 40% of patients, although the median duration of second remission was only 3 months. The selection of a salvage regimen will depend on how intensive the patient's initial therapy was, whether or not the relapse occurred while on therapy, and sites of relapse. In NTB's case, his regimen should include intensive therapy, preferably with chemotherapy drugs and regimens to which he has not been previously exposed, because his relapse occurred while he was on therapy. Additionally, he will have CNS radiation and intrathecal chemotherapy aimed at treating his specific sites of relapse. NTB's family is quite concerned about the poor prognosis associated with his relapse and inquire about the role of hematopoietic cell transplantation, abbreviated as HCT, in his relapse treatment. My questions to you read: should he be considered for hematopoietic cell transplantation at this point? Knowing the potential morbidity and mortality associated with allogeneic transplantation, would autologous transplant be a more appropriate option for NTB? Allogeneic hematopoietic cell transplantation is emerging as a superior treatment option for children with relapsed acute lymphocytic leukemia, who have high-risk and intermediate-risk features. In patients who receive a matched sibling hematopoietic cell transplantation during their second complete remission for relapsed acute lymphocytic leukemia, event-free survival rates of 52% at 5 years have been reported versus chemotherapy alone, producing 5% event-free survival at 5 years. Autologous hematopoietic cell transplantation does not appear to be superior to standard chemotherapy for children with acute lymphocytic leukemia in second remission and should not be offered. NTB's family should be offered the option of allogeneic hematopoietic cell transplantation, and his family should be tested for an appropriate sibling match, as this offers lower morbidity than an unrelated donor. Because his outcome in transplant improves if performed during a second complete remission, he should begin reinduction chemotherapy, while hematopoietic cell transplantation is being arranged. If hematopoietic cell transplantation does not prove to be a feasible option for NTB, novel therapies may be considered. Nelarabine is a purine analog approved for the treatment of relapsed T-cell leukemias and lymphomas, and it has shown response rates, complete and partial remission, as high as 55% in pediatric populations. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 462.